Hi, everyone. Welcome to this year's hashtag See Arthritis event. This is Arthritis Consumer Experts' 10th year of hosting through the Arthritis Broadcast Network. This really cool, I like to think of it as conversation that we have with world experts in rheumatology who happen to be Canadian over the course of the Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting that is taking place in Winnipeg, Manitoba this year. And we're so thrilled to have as one of our first guests, Dr. Janet Pope. Dr. Pope, welcome to the studio. We're so thankful that you could take the time to sit with us today and talk to us. We are literally on the eve of the meeting, so we're going to pick your brain. You're a veteran of rheumatology, and you have seen pretty much it all. So we're very excited to have this conversation with you, and welcome to the studio.
Oh, great. And thank you so much, Cheryl. I think of you in such a positive way as really being a groundbreaker for the voice of the people suffering with arthritis or other arthritis conditions. And a decade, congratulations. That's amazing. Wonderful reports and covering off the CRA meeting.
Thank
So
you.
excited to go to Winnipeg. It's not going to be as cold as we thought it might be, so it's great.
I'm happy to hear that, as I'm sure all attendees are. Hey, listen, first I'm going to let our audience know a little bit about you, Dr. Pope. So Dr. Pope is a professor of medicine in the Division of Rheumatology and also Epidemiology and Biostatistics at the University of Western Ontario, the Schulich School of Medicine, and that is in London, Ontario, Canada. You're also the division head in rheumatology at St. Joseph's Health Centre in London, and it's a pity, Dr. Pope, that you can't do more in your day. I'm a little disappointed that you can't take on more than that. All kidding aside, we're so honored to have you. I think you've been a perennial guest on the show for the last 10 years. And we really want to just sort of start with helping our audience understand a little bit more than just the bullet points from your bio, who you are, and kind of situate yourself in rheumatology. What is it you do day to day in clinic and in research?
So thanks for that, Cheryl. So I do think of myself as a clinician.
Yeah.
I see lots of patients. However, of course, any good or hopefully excellent clinician is also an educator. So I'm passionate about educating for both patients, colleagues, etc. And I do research, and my research is clinical questions. And sometimes it's a question that I've come up with in clinic, and I can either prove myself right and sometimes really prove myself wrong. But whether you're right or wrong, you find out something and it helps, I think, in the end, a patient. It makes me a better doctor. So
Yeah.
those are the things that I do. And I see lots of people with rheumatoid arthritis, both early and established, and with the connective tissue diseases such as lupus and scleroderma, and teaching the trainees as well as I'm on formerly known as Twitter. I'm on X with a hashtag clinical pearls to really
And
teach.
you're highly followed, and your feed is excellent.
Thank you. Thank you.
Yeah.
And I get a lot of patients who are very willing to show off their hands or their rash or what have you.
Yeah, no, your clinical pearls pieces are, I find them just like, it's like reading an encyclopedia of rheumatology when I go to your feed. So thank you for that, and for that bit of information in addition to your bio information. Let me ask you this, Dr. Pope. What for you, we know you're conducting a workshop at the meeting, and we guess we kind of want to get a little sneak peek, our audience, as to what you're going to be talking about. Kind of what are the key takeaway messages really for patients who are primarily those watching uh, our
Right.
our interviews over the course of the meeting. This, I know the workshop is on saving time and getting Section 3 credits. And you said having patients thank you for not over testing. I actually quite love that. And I know there are some other things we're going to talk about in a few minutes, but tell us just a little bit of more about not over testing, but testing for the right things.
That's right. So, unfortunately, even common kinds of arthritis aren't well taught in medical school. And that's not the fault of the learners. There's cutbacks, there's all sorts of things where there's just not enough hours for the referring physicians, particularly the primary care or and sometimes nurse practitioners or others to get it right. They see diabetes several times a day. They see inflammatory arthritis perhaps once every several months, osteoarthritis, soft tissue rheumatism every day as well.
Yeah.
So part of it is really in the whole choosing wisely category, where basically it's important that ordering a test is not just the cost of a test. It's we want to do no harm. So if we think the likelihood is very low, as a, for instance, that someone has lupus, to do an ANA test that if it's negative rules out lupus for the most part, if it's positive, there's probably 100 times more people who don't have lupus than do. So it never rules in a disease. So 1 in 3 women these days have a positive ANA, and as a for instance, only 1 in 1,000 will have lupus. So you can see where I'm going with this. You can
Yeah.
do a lot of harm. So I think it's important that we do practice reflection to say, what am I doing? Because we all want to do a really good job. And I think we think and then we do, and sometimes what we do isn't as consistent as we'd like to report to others. As a, again, as a for instance, there's guidelines for doing bone density, bone mineral density, to look for thin bones, and the guidelines could be very broad, that I could actually test every man over the age of 50, and I don't think that that's very appropriate. So older age is a risk, but of course women, postmenopausal, use of glucocorticoids, severe inflammatory arthritis, early menopause, they're all far higher risks. And in
Yeah.
general, women start with less bone mass. So to get it right, you want to test the right people. And when you get the test, as again, choosing wisely, thank you for doing it, but what does it mean now? When someone's of medium risk, we don't know what to do. So high
Yeah.
risk, we know what to do. They need treatment. Low risk, that's good. They don't need treatment, and we're not sure when to redo their bone density. And it's not just when the payer will pay, our government system of each province. It's when we think that there might be a change in status, enough time to go by. The medium risk people are very, very difficult. And you could get 10 doctors and have 3 answers, yes, no, maybe so. So I think in a workshop, we have to be honest with ourselves. I think we have to know where our blinders are on. We have to realize that ordering for the sake of it is not a good enough explanation in today's complex healthcare system, because we can do harm. So that's what we will be talking about. I'm sure other things, it'll be very interactive, but that's the bottom line. I think a patient wants to know answers, but getting a test, I see it every day. A patient will say, oh, I got an MRI of my back. And I'll say, not facetiously, because it's important to the
Yeah.
patient, but what did it show? And they go, I don't know. It showed what they thought I had, and it's not surgical, no red flags. So it's very discouraging. People wait a year maybe in some provinces for that test, and the test doesn't change anything. And maybe it was holding up physiotherapy, core strengthening, exercise programs that the patients could participate in, pain control, etc. So I think we need to know, here's the expectation, and a test isn't going to change what I'll do, whether it's positive, medium, or negative, right?
Yeah.
So, these are important, and they're tough conversations. I get people coming in, we all do, who say things like, I really want to know, like, can you redo my x-rays? And I'll say, as a for instance, you do have knee osteoarthritis clinically,
Yeah.
but you're not failing medical management. You're not a surgical candidate. You might be someday, but you don't have those red flags of rest pain, night pain, failing medical management. So going off and x-raying and then a CT or an MRI isn't going to change what we do. So let's get on with fixing the problem that you can participate in, and that maybe we can help. Injecting a knee, topical, anti-inflammatories, Tylenol, orthotics, etc. So I think that being, knowledgeable about why we order and what it might mean to a person would help a patient, make an informed decision with their physician.
Yeah. This is a really tough conversation to have on my side of the health education sphere as well. And, we hear the same things you hear, but from obviously the patient perspective, Dr. Pope, and people, emailing us or contacting us through direct message off of X or Facebook or another social media outlet where people connect with us every day. And they're like, I can't get my doctor to do X test. And we have to say, well, there are guidelines, and there's no need to take a test unless there are supporting factors to actually have you undergo that test. And, having a test result, when you say there are consequences to this and you can do harm, a lot of that harm is psycho-emotional, like I go
Yeah.
away from it. We know rheumatoid arthritis has a test that's called rheumatoid factor. It's not diagnostic. It only assists physicians, people highly skilled such as yourself. It's confirmatory. It helps add to the body of knowledge you have, which is primarily the physical examination.
Yes.
But
Yes.
people see this rheumatoid factor test and they freak out and they want to have it tested over and over and over again. And so we're constantly trying to help people understand the role of testing and the fact that these tests are very expensive. If we could save through some of the campaigns like Choosing Wisely and put that money into actual reimbursement of treatment, or aiding you in paying for tests that actually are more confirmational, let's do that.
Yes.
Instead of constantly struggling for, another x-ray a month later. Uh,
Exactly.
so yeah,
Getting a unified voice as well. So, because I live in Ontario, I know what happens with our Ontario Rheumatology Association, and we have lobbied for two ways to get some tests
yeah,
that weren't reimbursed by the government system, the anti-CCP, more specific, but only
yes,
specialist to order, and the ANCA for vasculitis, only specialist to order, and removing that no one should ever repeat ANA test if their first one was positive, and they shouldn't have one within several years anyway, unless if the symptomatology has changed.
changes,
So
yeah,
things like that. So we want to add and subtract for better care then,
yeah,
and more, in a way, as you say, more cost efficient care, because there's only a pot of money that will run out.
yep.
We need to really do what will change the prognosis or the diagnosis along the way.
Yeah, and this is truly how research informs and advances practice, right? If we don't learn from what we're spending money on in health research and it's not reflected in current state practice, I mean, we're just not using what we're generating in terms of knowledge, right? Um,
Exactly.
Listen, Dr. Pope, this year's meeting, I want to get uh, to the theme of every year the Canadian Rheumatology Association and Arthritis Health Professionals Association choose a theme. And this year's theme is confluence and collaboration at the forks. So, which basically signifies, or is trying to signify through a few words, the coming together of what's called shared decision making. And so I kind of want to ask you, because I think everyone's answer is a bit different, but what does that mean to you? And how do you practice shared decision making on the ground in your own clinic?
Excellent question, because there is no one size fits all. And there would be something wrong if we didn't individualize for each person, each client, each patient that comes through. So, what do I mean by that? I might have someone who's um, well read, English as a first language, lots of questions. And for that person, perhaps the shared decision making might have a far more in-depth conversation than someone who, say, as a for instance, isn't as health minded. They sometimes acquiesce and say, well, my child said, like my adult kid
Right.
said I could do this, or I don't know, what should I do? And I guess at some level we have to do both. So I try not to be paternalistic, but in the end we have to make a decision. So sometimes We can overwhelm people. Too much information is sometimes then a lack of information and understanding. So I usually try to, as a for instance, a little tool that I use is I'll write down, it's just a few words like we could, we'll say in advanced therapy and rheumatoid arthritis, we could use A or B. Well, we could use A, B, C, D, E. But if you have five choices, no one's going to decide. So the
Yeah,
two most popular for your conditions, for your disease state, maybe knowing you are, as a for instance, seropositive or seronegative, might be drug A or drug B.
right.
Here's both of them you have access to. No point in talking about stuff I can't get you anyway, right? And here's why you might think of A, and here's why you might think of B. So it's a message of hope. I don't say, oh, this one like could give you sores in your mouth, and this one high infection risk. It's more, here's the benefit, here's potential side effects, and here would be a reason why. And if you don't have a gut feeling at the end of that, that's okay.
Yeah,
Here's some easy, the room info, Andy Thompson's room info, drug information sheets, um, and have a look. And then my nurse, I have the luxury of that to say, my nurse, we can call you back in a week and a half.
yeah,
Just give them a date, an arbitrary date, so that they have time, and they might want to discuss it with their loved one or just think about it. Other people say, I'd much rather have A than B. I don't want an IV. I would like a pill or whatever. And
yeah,
that helps. Or my friend had this other one and it was really good. And I go, well, that's great, but you don't have the right disease for it, right? Like, we're glad that your friend's doing great, but that we don't use it in this disease.
yeah,
And I think sometimes when people can't decide, I do try to make analogies. This is like going to a restaurant. Most people have more than water. So you got to
yeah,
eventually order off the menu. But the nice thing is there's a menu. And if you don't like it, you can take it back.
yeah,
Try
yeah,
something else on the menu and you don't need the full meal. I
yeah.
would love you to have the full meal, but let's start with at least a main course.
Yeah, exactly. I think really what you're speaking about in our world, in our patient education world, is you're having a health literacy conversation. You're using health literacy tools in order to help build knowledge in the person that needs to make the decision. I think the modern patient more and more is someone who is going to participate in shared decision making. They don't want it to all be on you. They are looking to you as a guidepost. I always view my own rheumatologist, Dr. Pope, as my mentor in rheumatology. And
Right.
I learned from my mentor, and then I try to practice what I've learned. It's really, that's how I view it in my own patient world. I have rheumatoid arthritis for 35 years now. And what you described, this list making, here's A, here are the pros and cons to A, here's B, here are the pros and cons to B, based on your symptom profile, your life context, your religious beliefs, your cultural practices and beliefs. And here is how we can arrive at a decision together. When you boil it right down to that, people feel powered. I don't like the word empowered, because that's something you still do to me. I want power. And the power you're giving me in that scenario you just described is you've given me the power of knowledge. And
Exactly.
yeah,
And
not
hope
many
and
physicians
hope
are
and
willing to
hope.
do that, Dr. Pope.
Right.
Yeah,
That is true. Although I think the more and more the more contemporary
I
training,
agree. I
young
agree.
ones are
Yeah,
more used to it. And I think what's most important, and this is really impactful, is if we make a decision, it's not forever. We
yeah,
can backtrack, we can backpedal, we can go. I always say if there's an exit on the highway and you miss it, didn't work out, or it stopped working, right? Or it wasn't well tolerated, there's another exit. Or
yeah.
you can
It's
take a U-turn and we can
exit
try something.
32A, or you could
Yeah,
take exit
right.
32B. Yeah,
Right. And I think that that helps because I mean, we're so fortunate in so many of our diseases now that we have more than just one treatment, right?
yeah,
There is
yeah,
never one size fits all, but also we have a lot of potential avenues to follow or exits off the highway to follow. And I
yeah,
think that makes it less scary because someone's always worried about, we think of if you're complacent because you go, well, I guess I'm good enough. And sometimes we're pushing a little bit to say, I think that you could even be better. And what that means for you today is less pain and suffering. But what it means in 10 years might be less damage, more function that's maintained. And
Yeah,
so, we can always try. And then if it doesn't work out, that's okay.
yeah,
Or you don't have to decide today. This isn't an emergency, but we need to get on with it. And I
yeah,
think all those tools are helpful. And I think for the newer rheumatologists, the trainees, they also tend to adapt different styles because they see different mentors of their
yeah,
teachers and say, I like this, I don't like a list, I like that, I like something else.
yeah. You know, I imagine people are watching. This happens a lot with you, and they say, geez, I wish Dr. Pope were my rheumatologist. Um, all rheumatologists are in Canada. We're so blessed with an incredibly skilled, highly cohesive, I think, group of specialist physicians. You guys, there aren't many of you, what, 400 or 450 in the entire country. So you talk often, you collaborate on research. So it's a really tight-knit community, and people watch these things and see, real mentors and professionals like yourself, Dr. Pope, and think, oh, I wish I had that. And what I want to point out to our viewers is that what you and I are doing is what should happen in a clinic. You talk. Communication is the number one tool we have in healthcare, in my view. It is when I'm finally in front of you for my appointment, being prepared, having a short list of questions that you can get answered, hopefully in that clinic visit. Have a list you leave behind if you don't have enough time. Leave it with the nurse or the medical assistant. That's okay to do as well. But the bottom line is, we rheumatologists and me, patients, we have to really sharpen our communication skills in order to build health literacy that then creates the right environment for shared decision making. It's imperative.
It is imperative, and it really, as you say, it's almost like doing homework before
Yeah,
a visit, and because in honesty, my agenda is never identical to the patient's agenda, nor should it be. I have
yeah,
to make sure, what prescriptions do you need? You need your labs, I need to explain this, I need to problem solve around, I don't think this is a side effect, remember you had it before we started, but this seems like a side effect, maybe we can alter the dose or what have
yeah,
you.
yeah,
So that's my agenda. And also, are you in remission or not? And we do get a lot of mismatch, and it's very frustrating from a patient perspective. I know it is that, as if, for instance, I might say, or a trainee might say, you're doing great. And you go, well, you obviously didn't read my scores. I'm 10
yeah,
out of 10 on pain. I can't sleep. And it's more like, your rheumatoid is doing really well, but something else is causing this pain and suffering. What's going on at home? Oh, do you have a bad back right now? That's not your rheumatoid. How can we help it? Or maybe we can't help it,
yeah,
and I can send you to someone who can. So I think, to meet the needs of a modern individual coming to a clinic appointment, I think we do have to have we have to be alert, and we have to say, because we can get close-ended very quickly. We have to say, like, what am I missing here? Is there anything
yeah,
else that you'd like to talk about? Tell me what's on your mind, because I've told you all the stuff on my mind about you. You
yeah.
tell me about you in whichever order.
Yeah, I think that's such a great point about your list versus my list. I've just written an email actually to my rheumatologist last night saying I need to book an appointment. I've had fairly stable, well-controlled disease, but I can start to see a slip. I said I'd like to talk about possibility of changing up my medication regimen. I'm having problems now kneeling. I have I'm having inflammation in some joints that I haven't had in decades. So, and I'm stressed with my job, and I'm worried about my future. That's my list.
Right.
Right?
Right.
So you can see how different they are, but how they have to come together in order to deliver health to someone like me, which is your goal as a physician, obviously.
Absolutely.
Yeah.
Yeah.
Really cool conversation, Dr. Pope. Thank you. What is exciting to you right now in terms of either things happening right now or things that are on the horizon or things where you can peer, deep into your crystal ball and see something exciting coming along for people, not just living with RA, but for for whatever it is you see. If it's specific to a particular disease population, great. But I'm really curious to hear from you, because I view you, and I know our audience members who know you well view you as a sage in the community. So, sageness, give us give us your pearls.
So first of all, it is a crystal ball. So,
Yeah,
and many people will have similar, and some will have very divergent perspectives, which is great.
yeah,
So, I've got a near crystal ball and a more remote one. So my near crystal ball is there's a lot happening in systemic lupus erythematosus,
right.
lupus, SLE, and I think that probably within a couple years we will. I won't say turn treatment right over, but we will change, try to use far less prednisone, glucocorticoids,
Yeah,
dipomedrol, solumedrol. So the prednisone stuff. We will treat lupus nephritis more effectively, front end loading with the appropriate amount of drugs and then backing off over time or adding new ones. We also will have the potential, if these trials are positive, of possibly two new oral second or third line therapy drugs in lupus, like beyond hydroxychloroquine and celseptarese, azathioprine, or
yeah,
methotrexate. And we do have two biologics approved in Canada and coverage in some provinces, and we think more to come for them. So
yeah,
I think there will be more hope for lupus patients than we've had in a long time. And
yeah,
there's a lot of other trials that aren't as far evolved as what I've mentioned. So that's one thing. The other thing that is not so much near future, medium future, and then I'll do the
yeah,
distant. I think there's an awful lot of research going on in osteoarthritis. We really don't have the holy grail of trying to protect and or regenerate cartilage. And degenerative arthritis or cartilage damage is a final common pathway of many kinds of arthritis, but particularly osteoarthritis, but crystal arthritis, and some of our people suffering from inflammatory arthritis. In good spells, when their inflammation's good, they can get secondary osteoarthritis, trying to almost like the body trying to remodel. The inflammation's gone, let's try to heal the best that we can. I think that, a timeline of maybe 5 years, we're going to get drugs, because this is, well, I say 5 years. Others might say tens. I don't think anyone's going to say
like
3 years.
with my
But
RA fingers, I'm crossing.
yes, absolutely. But I think that because, first of all, um, this is a common problem in the general and aging population. So it is a multi-billion-dollar industry, which is a really good thing, because then pharma sees an unmet need and it helps people. They
Yeah,
can make money and we can get help. So I
yeah,
think it's great. And then I think in the further will be that AI will really be helping us. So artificial intelligence, sort of to say, um, let's try to crack the code in something really severe, such
yeah,
as systemic sclerosis, scleroderma. So I think with AI, and I'm just giving an example that's hypothetical, I think AI will help us really with the promise eventually of the right drug and the right patient at the right time, or getting the patient to the right clinic, getting that diagnosis faster. And it seems right now sort of space age, but my parents never would have thought that we could have a Zoom meeting, right?
I didn't before 2019, I'll be honest. Yeah, wow, those are all very exciting, and I like that, this is right at the surface of the crystal ball. This is a little bit deeper in it, and this is really a bit further away, but something to keep our eyes on. Any sort of final pearls for people like me who, for a short amount of time or a medium amount of time or a long, long time, been living with one of these complicated diseases that you look after? Any kind of closing thoughts on sort of self-care? How can we take state-of-the-art knowledge that exists in your world and apply it to our world on our own? I think, I mean, you well know, when someone gets a diagnosis like rheumatoid arthritis or like lupus, you, in one breath of hearing that news, your whole world is tipped upside down, and you start questioning uh, everything. The why me question sits over top of us almost
Right.
our whole lives. So, what do you say?
Yes.
How do you take today what we're calling modern patient? How do we help power them to better
Right.
self care? What do you think are
Right.
critical ingredients?
Right. So first of all, and you don't always hear this from your healthcare providers, but number one, be good to yourself.
Yeah,
You can't you can't help the rest of the world if you're not good to yourself.
yeah,
And you know what? We are a conglomeration of good, bad, and ugly. It depends on the day, it depends on how you feel, it depends on everything. So number one, be good to yourself. Don't be hard on yourself, forgive yourself.
yeah,
And that's so important. Number two, as you say, you didn't do anything to cause this by the vast majority of the diseases we see as rheumatologists. These are not um, diseases of addiction, as a for
they're
instance,
not lifestyle, quote unquote
yes,
lifestyle.
exactly, exactly. But you you can escape learned helplessness, and learned helplessness is a real problem, because if it's help me fix me, it's not even an even partnership. I
Yeah,
can give really really good medications, but if they're not taken, if people don't try to help themselves by, again, being good to themselves, eating as well as they can afford to, exercising, getting proper sleep, saying no to others so that you can pace and not, if you say yes to everything, you might be burning the candle at both ends just too much.
yeah,
So I think that with a chronic condition, it's really good to sit back and reflect and say, you know what, I didn't plan this for my life, but I can try to be the fullest that I can be despite this other thing. I always say it's like an umbrella over your head with the black cloud. But you know what? We need rain sometimes. And
yeah,
so, and I'm not saying people need illness or that they need pain, but I think it helps them to maybe have an awakening to say, if I do try to manage my stress and eat well and be good to myself and forgive myself, and then you can help yourself and others a little bit more. And really, the satisfaction of life is not just self-care, even though that's very important and should be number one for everybody. The satisfaction is then helping others. It might be spreading the word, it might be doing a leisure activity you love, it might be, the nieces and nephews. There's so many ways. And so I think that that is super important. And
yeah,
I think from the medical side of things is, as rheumatologists, we can learn from other specialists. We can learn from oncologists, maybe front end loading meds, not like with good safety, but doing better and backing off over time. That's more an oncology model. I don't mean cancer drugs, I mean just
yeah,
using it more effectively. And
yeah,
from the GI perspective, they're really smart at saying there is not one dose of a drug for every individual, say with Crohn's or ulcerative colitis. So I think we will probably get into more personalized medicine, which treats people like individuals. But we
yeah,
need the science to catch up and to help us. And it would offer then even more hope if drug A didn't work at regular dose, but if drug A is proven at double dose, as a for instance, or half dose, as a for instance, in some people, it will be equally effective but more safe at lower dose,
yeah.
or equally effective and or more effective and just as safe in others. So I think we will get into the point where we can actually use the drugs we have at hand, not just all the cool discoveries that will come, but the drugs we have at hand the best we can for our patients.
Yeah, that's so well put. And I'm listening to you and I'm thinking about this concept where you have that freedom to go up, to go down, to scale back. And what's required to support that is policy. And you being allowed to actually practice the art of medicine through good reimbursement policy, through good regulatory review, approval or not, and for manufacturers to understand that's the way they need to deliver their drugs. Dresses don't come, in one
One
size. They
size,
come in
that's
10
right.
sizes for a reason.
Yes, yes,
So there are really important factors that help enable you to do that kind of work with me, the patient.
Yes, and to get the science supporting it too,
Sure,
because I
sure.
can say doctor anecdote all I want, but if I can't prove that
No,
this makes
exactly.
sense,
Yeah,
then we're no further ahead. So I agree,
exactly.
absolutely.
So I guess what we're saying together is it takes a village and it takes
It
good
does.
policy, it takes good communication, it takes this incredible mix of ingredients to, be what you kind of quote unquote call successful in the partnership of rheumatology between person living with the disease and the person expert in treating it. And you are the most expert, Dr. Pope, and I'm just so grateful that you've taken the time to sit with us in studio and participate once again in our hashtag See Arthritis event. We wish you all the best. We hope the meeting is a huge success. I know it will be for you, the workshop that you're conducting, and we can't wait to talk to you again.
Great, thanks so much,
Thank
Cheryl, and good
you.
luck with all of the program.
And watch this. This is just on the heels of Valentine's Day.
Oh, I like it. Beautiful.
Just for you.
Thank
Okay.
you.
Be well. See you
Bye.
later. Thanks for tuning in, everyone. Bye bye.